So what happens in endocrine function test, we're going to break it down into, because there's so many hormones and the time that we have is limited because we're doing online classes nowadays. So we're going to break it down. So today, more particularly, we'll talk about the thyroid hormone and the thyroid function test that we require. So this and mostly um, growth hormone, these and cortisol, these three are very, very, very important because they sometimes ask you questions that get a little confusing while you're attempting your BCQs. So hence you have to be paying attention, like you have to really pay attention to it in order to answer your questions. The rest of it, well, because we've done diabetes mellitus, you generally have an idea that how you do diagnose that. Through, it can be done through fasting blood sugar, it can be done through um, OGTT, which is oral glucose tolerance test. But these are things that, and HbA1c also very important. Again, something that we've been hearing quite some time. Thyroid is also, it's not difficult, but it's also a little detailed because we have to always keep on talking about, we have to check with all the symptoms and everything. So it gets sometimes a little confusing. So when you're attempting an OSPE or whether you're attempting a BCQ, please make sure that you reread before trying to answer it so that you know that you're on the right track. So today, as I said before, we're going to do overview on thyroid hormones. Then we're going to talk about thyroid function test. We're going to talk about the interpretation of those thyroid function tests. So what happens with interpretation, we're just going to talk about how important it is to like what diseases and what conditions are associated and what results can we get if we perform the thyroid function test. And then there's again a review of interpretation where I'll be we're just going to be repeating whatever we've talked about in the previous. All right. So moving on, the thyroid gland is basically located anterior to the larynx and consists of two bulky lateral lobes connected by a relatively thin isthmus. In response to hypothalamic factors, which is TRH in particularly, TSH is released by thyrotrophs in the anterior pituitary into the circulation. So you have TRH, which releases TSH and then goes on to in the circulation. Now that TSH ends up binding to the receptors and on the thyroid follicular epithelium, resulting in activation of the receptor, allowing it to associate with G protein, and moreover, it causes activation of that and hence releases CAMP and causes the hormone synthesis to occur. So overall, if we see, we've got two factors, TRH and TSH, which both are very, very important. So TRH is released, causing release of TSH. Now that TSH will go and attach itself to the receptors on thyroid gland, which means that it will result into activation of G protein, moving over to activation of CAMP or CAMP, then resulting into production of thyroid hormones. Obviously, there's all that process that you've probably read in physiology where they're talking about oxidation, iodination, and all of those things. So we're not very particularly concerned with those at this point. Okay, so this is a picture taken from Robbins. So this is just showing you that it's just sort of like a review, like I said. So I always keep on repeating these in my lecture that the reason why I keep on adding tables and diagrams is because it's easier to understand, it's quicker to understand. And once I've taught it, I'm pretty sure that you can, even if you look at these in your book, it will be easier for you to understand this rather than go through the text and pick out things that are important. Okay, so here again, we're talking about the same thing. This TRS that is being released from the hypothalamus going on to pituitary, which will release TSH. Now that TSH will again attach itself to the receptor on the thyroid releasing activating G protein. That G protein in turn will increase the levels of CAMP and hence will cause the entire process to occur in which the thyroid hormones will increase. And then those thyroid hormones, T3, T4 particularly, will go on to act on a cell and work accordingly. But in this diagram, what they've also shown is that they've shown you the negative feedback reaction as well. So the negative feedback reaction is just showing how when there's an increase of T3T4, free T3T4 in the circulation. What it does is that it sends a signal to the pituitary to stop releasing TSH, and and in turn will also send a signal to the hypothalamus saying that they need to stop producing TRH as well because there's already too much of it in the um, in the circulation. I hope these are things that you can understand. Okay, moving on to, so there are two sorts of conditions, well, mostly symptoms that you can find. It is hyperthyroidism and hypothyroidism. So in case of hyperthyroidism, how do you define hyperthyroidism is you see a patient and you will see certain features such as um, exophthalmos, you will see tremors, you will see heat intolerance, there will be insomnia, there will be menorrhagia in case of women, and it will lead on to amenorrhea. There will be thin and lean, excessively thin and lean. So all of these are symptoms to hyperthyroidism. In case of hypothyroidism, you have symptoms such as somnolence, um, increased appetite, fatigue, lethargy, and there's also this myxedema that you will see in such patients. But this is just a brief overview. Again, I'm pretty sure that you guys will read up hyper and hypothyroidism on your own and know what the symptoms are. It's just for an overview. Okay, again with different disorders that are associated with hyperthyroidism, we have Graves' disease, most commonly. You have toxic multinodular goiter, toxic adenoma, iodine-induced hyperthyroidism, neonatal thyrotoxicosis associated with maternal Graves' disease. And in secondary, you have TSH secretory pituitary adenoma. So the most commonly that you see is Graves' disease. In case of, like if you are going to ask me how will we know that whether it's a multinodular goiter or adenoma. So in all of these things, you might have to perform a biopsy at the end of the day to know for short what it is instead of beating about the bush. That's what you can do here. And then you have causes of hypothyroidism that might be a genetic defect in thyroid development, mutations in the TSH receptors, they can be thyroid hormone resistance syndrome, but these are rare. So the common ones that you get is autoimmune hypothyroidism, which is more particularly Hashimoto's thyroiditis, and you get iodine deficiency. There are different drugs such as lithium iodides, aminosalicylic acid, and then you have congenital biosynthetic defect, so you can get that. In secondary, you can get pituitary failure or hypothalamic failure. Now that can occur in, let's say, case of Sheehan syndrome. So pregnant lady who undergoes excessive bleeding while during birth can have necrosis of the hypothalamus due to lack of blood flow. So that may also result in hypothyroidism. So you need to keep all of these aspects in mind when your patient comes to you in the clinic or when you see someone. See, it's not necessary that you can see a patient only in a clinic and diagnose them. You can see these cases all around you. You know, the best thing is if you see someone walking, you just give a quick look and you and someone's sick looking, like don't become really obsessed with it, but someone's sick looking, like someone is being taken on a stretcher, and you look at it and you should have, oh, this might be it, you know, this disease might, uh, this is what they're suffering from. So this is it's a good nice game. It's just something to pass time and good for revision as well. Okay, moving on to the topic of the hour, thyroid function test. So in order to define a particular condition, thyroid function test are performed. So it's also known as a thyroid panel. You can get it comes from different names when you go to the lab. Um, so you have what they primarily look for is TR. Sometimes not even TRH. Primarily they look for TSH, 3T3, T4, but sometimes TRH may be added. Depends. But mostly TSH, FT3, and FT4 are tested when we talk about thyroid panel. Okay, any questions so far? Okay, so I'll just move on. Thyrotropin releasing hormone stimulation. Now, what happens that if you suspect a person with secondary hypothyroidism, it's very important that you perform a TRH test. So, small amount of TRH is given through an IV, and then the blood is taken for the levels of TSH. Because as we already read that TRH causes increase in levels of TSH. Patients with normal function of hypothalamic pituitary axis respond by increasing the levels of TSH. Now the normal phenomena that we talk about is TRH will increase TSH. But in this case, what will happen is that because the patient has a compromised function of hypothalamic pituitary axis, they may exhibit, they may not respond to that TRS, that exogenous TRS that we have given. So there's a delayed response, there's an absent response, and TSH will not increase. And this is a useful diagnosis in case of secondary hypothyroidism or central hypothyroidism, as you want to. Moreover, if you have given a TRH, you can also test for T4, T3. You can also test for both of those. So what will happen at the end of the day is that regardless of how much TRH is given, it will never it will never stimulate TSH or K4, and you will see low levels of it, and at times maybe normal levels of it, but not you will not see an increase as it should be when given extra TRH than a normal amount. Okay, so the next one that we have is TSH. Now, like it said over here, TSH is the first line of investigation. With FT4, which is free thyroid hormone 4, is indicated as the second line test used to investigate situation in which TSH abnormalities are found or where TSH measurements are unreliable. So, wait for it, I've got a diagram later on which we have to discuss that will connect you with all the conditions where we see TSH and PT4 just to see how it's going to work, like how it can be associated. So free T4, what it does is that it's a second line and usually used when TSH is unreliable or where TSH may not, abnormality may not be found as well. All right. Free T3 is only used for diagnosing a thyroid toxicosis or hyperthyroidism or for monitoring T3 replacement therapy. So it may occur in patients who had hypothyroidism due to whatever reason. and they are given thyroid hormones exogenously. So this is how we test it in order to keep it under, like it's a controlled environment that we have to look into. When interpreting discordant FT4 and TSH results, the TSH test usually yields the most diagnostically reliable results. Now, if compared between FT3, T4 and TSH, TSH is the most reliable source of all these things. Now, there's also a condition of subclinical thyroid disease, and it's very common. So, in that case, nowadays it has become very common. So, in that case, what happens is that you have an abnormal TSH and you have a normal level of free T4. So, you have to, this is one of the ways that you can infer. So, all I'm telling you right now is how to be able to infer when you look at a thyroid panel. And just to know how you can, jump. And it's not necessary that just because you've seen a lab result, it might just be, it's not a definitive diagnosis again. You need to see a patient clinically, you take a good history, then you have a good answer to it. Like it's like an educated guess. Um, it's like an educated guess that's sort of like 80% you should be able to identify through your history and examination, and then 20% should depend on your lab investigation. So then, hence on, you can give them the correct treatment. Okay, so rare causes of inappropriate TSH includes TSH secreting pituitary tumors and syndromes of thyroid hormone resistance. So, like we discussed in a statement before, that PT4 is the second line and is usually used in case that TSH measurements will be unreliable or abnormal. So one such condition can be TSH secreting pituitary tumor, or it can be thyroid hormone resistance. So keeping this in mind, this can become a very, this can be a BCQ. So please do remember this one tiny detail. Any questions so far? Any questions you guys have, please tell. Also, one more request that I have with you guys is that, can you please do a favor when you're on, when you've registered on Edmodo, there's a way of changing your like username by which we get to know you. Please do add your roll numbers to it, because it becomes very difficult for us to mark um, your attendance in order to see who's given in their assignment, who hasn't. Because what happens is that some of you don't write your first name and end up writing, from their second name. And then sometimes it becomes really difficult for us to find it on the sheet, because there's so many of you. So please either do mention your roll number. It'll be really easier for us if you do that. All right, so I'll just move on. Okay, so this is what I talked about when I said we'll have a little bit of review of interpretation of the thyroid function test. So this one particular diagram is, or flow chart is showing very clearly 2 to 3 things. Number one, you have the hormones that are being tested. Number two, we're talking about if there are different levels of it. All right. And number three is talking about different conditions that those levels can represent. So three things all concised into this one particular flow chart. Uh, the the presentation will be up in a bit on Edmodo. So if you guys want, this is a very important and very helpful. So if you guys want, you can put, like go through it over and over again. And this will help you. Like if you don't have time to revise much, or you just want it for a little review, or you just want to recap what you've studied or something. So you can always go through this and it'll be easier for you to understand all of those things that are there. So firstly, we talked about that TSH is the first line investigations that we do, along with T4, which is uh, a second line. T3 usually just only occurs in cases of thyrotoxicosis or hyperthyroidism. So that's what we tested for, right? And TRH is only in cases of where a patient is suffering from central hypothyroidism or a secondary hypothyroidism. All right, it's one and the same thing. The words are interchangeable. Anyway, so if we have, so first we do TSH testing. Now, if we have a normal level, then you do not obviously have to do any test. You don't have to test the patient. Furthermore, you have to look into other things. If it's decreased, then you will go for second line. That is free T4. Now, if the free T4 is low and the TSH is also decreased, that might indicate that the patient either has central hypothyroidism or is severely ill where the thyroid has shut down itself. Um, Secondly, if you have a low level of TSH with a normal level of free T4, that may indicate 3 toxicosis. So in that case, you will immediately go for a T3 level. And if not, it may also indicate subclinical hyperthyroidism. So you see how your diagnosis gets narrowed down with every single of it, with every single test that you do. Third possibility that can happen if you have a low TSH and an elevated T4 level is that it's just indicating hyperthyroidism. So in that case also you can do T3 just to see how and whatever more is required. Are both of them increased? Is only one of them increased? And this may indicate um, let's say Graves' disease. So then again you have to go towards further testing just to be completely sure and to determine what kind of treatment can be done on the patient. Okay, so in case of an elevated TSH, what you can do is that when you have an elevated level, so you will go for a free T4 test again. Again, like I said, TSH first line, T4 is second line. Okay, so if you have a low level of T4 with an elevated level of TSH, that indicates hypothyroidism. Now, there are a lot of diseases, autoimmune diseases that can, like Hashimoto's, that need to be sorted out, or iodine deficiency that needs to be sorted out. So, no, all of those things needs to be looked into. So if you have an elevated TSH level with a normal free T4, you will have a subclinical hypothyroidism. That is an indication for it. So with subclinical, the thing is that patients are mostly they don't have the symptoms, or they have the symptoms but they're not, it's not affecting their daily life, or it's not really affecting them overall as much as in case of hyper or hypo. So they're somewhat like normal. So you need to be very particular. You need to be very. You need to have a keen eye over such patients because they do show up, and then you have to treat them accordingly. Um, in case of an elevated level of TSH and you have an elevated level of free T4, it is definitely a TSH secreting tumor, because the more the TSH is being released, the more T4 is getting, because or it can, like I said, it's causing a central hyperthyroid, case of central hyperthyroidism. So what, or secondary hyperthyroidism. So what is happening is that there's like an adenoma or something that has resulted into TSH being released more than the usual amount, and that because the thyroid itself is um, governed by TSH. So what happens that the same process that we talked before, that TSH will result into attaching itself to the receptors of the thyroid, resulting into activation of G protein, resulting into increased levels of CAMP, and resulting into formation of thyroid hormones. So this is exactly where this is going about. So any questions so far? Do you guys want me to repeat it all over again? Okay, I'll repeat it again. Um, so we talked about first line being TSH testing. Okay, so if it's normal, you don't have to do anything. Send the patient. Look into some other reason for patient's illness. All right. But if you have um, if I'll just come back to that. Let me revise that and I'll come back to your question. So it's normal. You don't have to do any more testing. So what you can do is that, but if it's, let's say, decreased or elevated, in both cases you have to do pre T4. All right. So let's just talk about when TSH is decreased and the different levels that you can come up with in case of pre T4. So TSH is decreased, free T4 is low. That will mean central hypothyroidism. In case of decreased TSH and T4 being normal, that means subclinical. It can be subclinical hyperthyroidism, T3 toxic. All right. In case of TSH testing, we do the TSH and it's decreased, and free T4 is elevated, it means hyperthyroidism. Now that can be due to various reasons that we've talked about in the previous um, slides. Achha, now that we go on to the other side of it, so we have TSH that's elevated and we have free T4 that is low. So it indicates as hypothyroidism due to the various reasons that we've talked about in previous slides. Again, TSH levels being elevated with free T4 being normal, it is subclinical hypothyroidism. And if you talk about an elevated T4 in case of an elevated TSH, that means a TSH secreting tumor. So all in all, like I said, this is like a very nice, brief little, like that you can use up. Okay, so one other question that someone asked was, can there be elevated levels of T4, T3, T4, even if TSH is decreased? Of course there can be. And why is that so? Because you can have a tumor that is secreting, that is acting upon the thyroid gland itself. So, like it's like, like a child can be completely out of control even though they've got parents. That is exactly what happens to a thyroid gland. So because of a tumor, it goes completely out of control and it keeps on producing T4 and T3, and regardless of whether there is TRH or TSH, or so they don't need like another, they don't need orders from the center to tell them how to go about it. They're just doing it on out of their own free will. Um, so that's when you can have a decreased TSH, and you can also have decreased TRH in the same case with an elevated level of T4, maybe an elevated level of T3, maybe a normal level of T4 and elevated level of T3. So it can go either way. I hope that answers your question. Anyone else who has an issue that you would like to discuss over here? Okay, guys, so I'll be putting up this presentation in a bit along with your assignment. Please do attempt those. Do not miss out on it. It's very important because through that I do understand whether you are getting it or not. And it becomes easier for me. So if